All right, welcome to this session on Hope for the Future. This session is near and dear to my heart. Anybody who knows me knows that I really love to talk about all things research, so this is exciting. I am going to be joined today by an oncologist, a nephrologist, and a surgeon for this amazing session. And if you would like to learn more about the individuals who are going to be presenting today, Dr. Brzezinski, Dr. Drake, and Dr. Murphy, please check out the virtual program where you can see their full biographies. But we won't waste that time here now today. We'll move on. And I'd love to start off by introducing you to Dr. Brzezinski, who's going to kick us off.
Thanks so much, Robyn. Really nice to be here. Appreciate the invitation, and it's great to speak with so many families and a little bit about some of the stuff that we do that isn't directly affecting patients right now, but that we hope will soon. So if we can go to the next slide. So this is what motivates a lot of my work. There's a lot of different ways that people divide up renal tumors and talk about what the risk is of relapse. But let's say we take the group that we would consider good event-free survival, which means, here in this way it's divided up as saying 75 to 84% after normal therapy will have no relapse. And I'm going to represent that with just a group of children on the side where you have these 16 children in green don't relapse and the 4 do relapse. So that's what we know so far about this group. But I think there's a lot more that we need to learn. So if we go next. So these children in blue might be at a very high risk of getting some form of late effect. Maybe they get, kidney dysfunction. Maybe they have a risk for a second cancer. These are children who maybe would benefit from a little bit less therapy. And then if you go next again. And then we also know that there's probably children who, and these would be the ones in purple, who would have survived with less therapy. And probably they could, and they could probably get less chemo, less radiation, maybe even a smaller surgery. But the problem is that we don't do a great job of picking out those children right now. We don't really know who they are, and no one really wants to risk, causing a relapse because you're trying to take therapy away from children. So what I'm trying to do, if you go to the next, or skip the next slide, sorry, go to the next slide and skip it again. We're going to skip that one. So what I'm trying to do is use a slightly different way to try to identify, yes, patients who might be at higher risk of relapse, but more importantly, patients who are unlikely to relapse, so that we can try to start taking some therapy away from them, making the therapeutic journey a little bit easier, and trying to reduce that risk of late effects. And so what I focused on is something called DNA methylation. And you guys have probably heard over and over again about genetic changes. We look for it in Wilms tumors. We look for big changes in the genome, like gains of 1q, that's a chromosome. We look for little changes, like little mutations in WT1 and other genes. But DNA methylation is a mark that is on top of the DNA. So it doesn't change the DNA itself, but it changes how the machinery in the cell reads the DNA. And it tells the cell whether to read a gene or to not read a gene and when to do it. And that has a massive effect on how the cell proliferates and how it divides. And this is, interestingly, a mark that is very stable, so it stays the same from cell to cell. We know that it is very highly affected in Wilms tumors. We have lots of evidence that it's highly affected in Wilms tumors. And it's quite easy to measure. We have lots of great ways of measuring it. So my focus has been looking at how we can use DNA methylation to try to identify different subgroups of patients who might have better outcomes than we initially thought. So if we go to the next slide. Next slide. There we are. Great. So in a nutshell, and there's a lot more to this, but within 5 minutes, it's hard to get to it. But what I'm going to tell you is that, one of the big discoveries I made early on that a lot of what I work on now is building off of is the idea that we can actually use DNA methylation to find at least 2 subgroups of patients with Wilms tumors. And the subgroup A, which I'm marking in green, those ones, when you look at how their DNA methylation looks, you just look at all the DNA methylation in the genome, it looks a lot more like a normal kidney. than the subgroup B, and the orange is normal kidney. So you can see on the right-hand side that the green dots are very close to the orange dots and the blue dots are separate. And unsurprisingly, the ones that look more like normal kidney are the ones that seem to have a lower risk of relapse. And so far, we're showing that that risk of relapse seems to be low, and we have many validation sets where we're trying to prove that. And if you go to the next slide, what we're really focused on now is trying to use cell-free DNA to actually pick up those DNA methylation marks, because we know that we have at least two subgroups. They're both specific to Wilms tumors. And if we can find the DNA methylation marks in the blood, then we can use that both for diagnosis, but possibly for prognosis as well, so that we can find out who is at a higher or lower risk of relapse before we even do the surgery and possibly affect our surgical decisions by looking at that. If we go to the final slide, we're now showing some evidence that we can do this. So looking at DNA methylation in blood, so here you have red dots are patients with Wilms tumors, and gray dots are all clustered together. There's 4 of them. Those are patients who never had a Wilms tumor. They're just healthy kids. And what we can show is A, we can separate the children with Wilms tumors from the children without Wilms tumors just by looking at blood. But B, the subgroup A tumors, which are on the left-hand side and are circled in a smaller circle, those we can separate out from the subgroup B tumors. So we're starting to develop this evidence, and not only can we find the children at low risk of relapse, but we can actually diagnose Wilms tumor in blood, and we can maybe prognosticate it. And I'm going to just leave it at that so that you can hear some more exciting stuff from Keri and Andrew.
Great. Thanks so much, Jack. So it's such a pleasure to be here today. As a pediatric nephrologist, I'm interested in ways that we can improve kidney-related outcomes for patients with Wilms tumor. And as a researcher, the goal of my lab is to use models and tools in the study of kidney development to try to better understand the early events that predispose to Wilms tumor. So from a clinical standpoint, we know that kidney-related outcomes is an important part of Wilms tumor survivorship. Next. And it's pretty fascinating to think that this all starts before birth, since the kidney develops in utero to form all the filtering units or nephrons that will support its function through adult life. And then the kidney continues to mature until about the first 2 years of life. And after that, we really have whatever kidney function we have to support the growth of a person through adolescence and through adulthood. And we know that no new filtering units are made after birth. And then after about age 20 to 30, we see a slow decline that normally happens with age. Next slide. So babies that are born early, before 34 to 36 weeks of gestation, are at risk for not developing as many filtering units as if they normally would have been born at term. Next slide. And then we know that any injury to the kidneys that can happen during childhood, like with chemotherapy or with nephrectomy, can put patients at risk for developing chronic kidney disease. Next slide. So it's really important to identify these things because we can provide medical management to help slow the disease progression. Next slide. So when we think about ways to identify patients that might be at higher risk, and then how to screen and follow patients in the future for long-term potential kidney-related outcomes, is one way that we think we can help improve survivorship for our patients. Next slide. So then in the lab, my research is focused on understanding how a small population of progenitor cells that are established very early in development can give rise to a complex organ like the kidney. So to do this, we have a number of tools, including genetically engineered mouse models with some pictures shown here in these images. And then we can also use technologies like single-cell sequencing, which is shown in this plot. So we can use this to see what genes are expressed in a single cell at a single point in time to better understand how the kidney develops. Since we know that Wilms tumor arises from defects in this normal development, these models offer a lot of potential to understand these very early events that predispose to Wilms tumor. Next slide. So ways that we are trying to understand how these early events in the fetal kidney disrupt normal development and can give rise to either precursor lesions as nephrogenic rests or directly transform into cancer. Next slide. Is to use these genetically engineered mouse models, since we can recapitulate this process by introducing genetic changes that are known to drive Wilms tumor into different cell types within the developing kidney. And then we can follow this process through nephrogenic rest lesions and into tumors that eventually show metastasis in the mice. And then we can utilize these techniques, including single cell techniques, to better understand this link, how they may drive tumor formation, with the overall goal of trying to identify therapeutic vulnerabilities that we can translate from our mouse work into humans and try to develop new targeted treatments that can improve outcomes for patients.
All right, thanks, Jack and Keri, for those exciting summaries of your research, and thanks to Robyn and everybody on the webinar for the opportunity to participate in the forum today and share some of my research ideas. Go ahead to the next slide, please. So Wilms tumor is understood as basically an arrest that occurs in kidney development. There are two cell types, these red and green cells, that interact with each other. The red are the metanephric mesenchyme. These are the nephron progenitor cells that become the functional units of the kidney. And the green are part of the ureteric bud, which eventually becomes the urinary drainage aspect of the kidney. And so there are a variety of different molecular events that occur in the red cell population, most commonly, that lead to arrest of this process, and those cells later become Wilms tumor. Next slide. And this has been known for a long time. Our lab and others are studying some of the specific molecular mechanisms involved, but really since Wilms tumor was first identified under a microscope, it was known to parallel this developmental process in the fetal kidney because it contains three main cell types that strongly mirror those that are found in the developing kidney. And these cell types are, number one, stroma, which are these supportive spindle-shaped scaffold-like cells. Next slide. Epithelia, which form these primitive tubular structures. And then next slide. Blastema, which are small, round, blue cells that have stem-like characteristics, essentially thought to be the stem cell component of the cancer. Next slide. And so our lab has been primarily interested in developing patient-derived xenografts. These are tissue that's taken from a surgical resection specimen when a tumor is removed from a patient with Wilms tumor, and then implanted into the flank of a mouse with a compromised immune system that allows it to grow. And we find that in contrast to many of the other cellular model systems available, that these patient-derived xenografts actually capture all three of these cell types, and importantly, the stem cell-like characteristics of the blastemal cells within Wilms tumor. And so we think that this is a good model for preclinical treatment studies, and one that mirrors actual Wilms tumors in human beings much more closely than some of the more traditional two-dimensional in vitro cell culture systems. Next slide, please. So we used this model system to understand chemotherapy resistance in Wilms tumor. So we took a patient-derived xenograft model called KT47, which you can see on the left side of this slide. This came from a patient that relapsed and ultimately died from their Wilms tumor. This patient had chromosome 1q gain in their tumor, which is associated with the need for intense therapy in order to avoid a poor prognosis. And what we did is we treated this model with serial cycles of vincristine, actinomycin D, and doxorubicin, which are three of the cornerstone drugs used to treat Wilms tumor. And we kept treating this model until it became completely resistant to these three therapies. Basically, the tumor just grew like we weren't giving it any chemotherapy at all. And then what we did is tried to understand the mechanisms that led to this. And they're listed here, but overall what we found is the kidney, the tumor cells revert or transfer back to like a stem cell-like state, one that's very reminiscent of developing stem cells from kidney development. And then we tried to understand these mechanisms, and in contrast to what we initially thought, it wasn't really like the acquisition of mutations in the tumor. It was mainly epigenetic mechanisms, so things that are occurring outside of the genetic code. Next slide. And so our question then is, how can we harness these epigenetic mechanisms to prevent these mechanisms of chemotherapy resistance? Can we use small molecule modifiers of some of the enzymes that regulate epigenetic mechanisms to push these cells away from being stem-like, away from blastemal states, and sensitize tumors to chemotherapy? So that's what I wanted to lead in with today, and look forward to further discussion with everyone.
That was great. Thank you so much for giving us a little bit of a background on what kind of, I mean, this all feels very much like the basic biology research to better understand those next steps to get into the clinic. So for a lot of families, it can feel like this stuff feels kind of far away from the clinic. So can each one of you kind of step in and talk a little bit about what does it take to get from the work that you're doing to where a family would experience some kind of change in treatment or protocol, or that their oncologist or their surgeon would have some different understanding to be able to affect the change in treatment. Does anybody want to tackle that?
I can start. I think that the work I do is probably just a little naturally closer to the clinic because we use tools that are somewhat available clinically. So for diagnostic tests, which is essentially what we're doing, what we need to do is first discover the finding that it's useful, which is step one and is done. Step two is we need to validate it in a much bigger group, which means we need to show, yeah, we showed in our group of about 100, actually, I think it was a little closer to 200, that we can kind of predict outcomes, but we need even more than that to convince people that this is something that can be used in the clinic to actually help to find therapy. And that takes several years because what that takes is recruiting patients prospectively and doing this test on them, or doing it retrospectively on a large trial. And these are things we do kind of in conjunction with groups like COG. And we have to all of us have to sit together and also prioritize which biomarkers we're going to look at, given that we only have so many patients we can test them on.
Okay, I'm going to step back for a second, Jack. You said the word prospective.
Sorry.
A second. Can you just step back for a second and tell us what you mean and what that means to a family who might be involved in a diagnosis?
Yeah, thank you. Thank you for stopping me also. So, many families who are diagnosed with a Wilms tumor, will have the opportunity to enroll on clinical trials. And sometimes the clinical trials are, interventional, by which we mean that the trial might choose one therapy versus another and try that therapy out and tell you, we think this one's better, but we don't know. And so we're going to try that and we're going to compare it to another group. That's an interventional trial. But also what a lot of you have signed up for is trials where we collect specimens and we bank those specimens, like from the tumor, maybe from blood, maybe urine, and they get put in a biobank, and that's collected along with some data about how that child does, right? And it's questions all the way from, what stage were they when they were diagnosed, and what were their symptoms when they were diagnosed, to did they, were they cured with their first therapy? Did they need 2 lines, 3 lines of therapy? Did they get radiation? Did they not get radiation? And we could put all of this together. And by collecting those data prospectively, which means as it happens, so not going back in time and trying to figure out, but collecting as it happens, we know that we have these very rigorous data sets where we can then compare and say, okay, well, now I want my biomarker. And if I can show in all those bank samples that biomarker is present in 20% of patients, and I have good data to show out of those 20%, only 1% relapse or even less, now I have a lot more confidence that that's a good biomarker. And that's really the next step for what I'm doing to bring it to clinic. And then the final step is really making sure the clinical labs or commercial labs are able to actually do it in a validated way. And that's a more technical issue. But the really the bigger issue is being able to get a good collection of data and samples from a trial so that we can show that this works in more than just our small set that we collected institutions.
That's great. Thank you. Do Andrew or Keri, do either of you want to talk a little bit about how you foresee the work that you're doing translating into the clinic and how that could affect care for children more, I guess more succinctly? I heard hints of it while you were talking, but maybe more directly say how you hope that this work will directly impact families in the future.
Yeah, well, I can say, I've described work that we do with genetically engineered mouse models, so it sounds really far away from, making it to the clinic and to people. But the mouse can be a very good model for studying kidney development. We know lots of things that go wrong in kidney development that don't give rise to Wilms tumor. So we think one of the powerful things with this model is that we can understand what are those specific insults that predispose to tumors. We'll better understand the biology, and that will help inform the studies that you're hearing that are describing of how we interpret those and apply them to patients.
That's awesome. Thanks. Andrew, anything to add to that?
Yeah, I would say that I think sometimes studying these developmentally relevant mechanisms seems like it's a million miles away from the clinic, and the reality is that it is. But I think in Wilms tumor basic biology research, we have a lot of organizing and catching up to do. I think it's if I'm just being honest, I think it's under-resourced, underappreciated. It's regarded as a curable cancer in children, and so it just doesn't get the limelight. And then what's compounded that is, for whatever reason, and I think it has to do with the cell type of origin, it's just notoriously more difficult to establish model systems from Wilms tumors compared to other cancers, especially adult, but even compared to other pediatric cancers, such as like neuroblastoma, osteosarcoma, etc.
Mm-hmm.
And so we just have to organize among people who are dedicated and interested in this to establish the fundamental model systems and the understanding of those so that we can build a really robust evidence basis for some of these preclinical studies before taking it to the next step, going to someone like Mike Ortiz, who you all just heard from, with a new idea for, developmental therapeutic in patients with Wilms tumor. So I think we have a lot of basic work to do.
Well, first of all, you are not going to get any arguments from the pediatric renal tumor community about the under-resourced nature of this. And I mean, we're really working to come together as a community so that we can help make sure that the resources are there. The cry of the heart of most families is going to be more effective, less toxic treatments. And everything you guys are talking about today ultimately leads to that, which is really important. So earlier today, there was a question about nephrogenic rests. So I wanted to step back to it because I felt like this group was really probably the right place to put the question. And that's just really, are nephrogenic rests, are these cells that you're born with? This is the question from the participant. Is this what do we know about it? What do we know about how and why they may develop into Wilms tumor? So I don't know who'd like to take a crack at that, but that was an important question asked earlier today.
I can tell you what I think about that. So, nephrogenic rests are a precursor to Wilms tumor. And so they can be thought of kind of like a colon polyp. It's something that is part of the way there, but there are substantial additional molecular events that need to occur before those transform into a bona fide malignancy. But in contrast to a colon polyp, I don't think that nephrogenic rests are something that are acquired. I think the evidence supports that they're left over from kidney development. Again, and it happens in so many different ways, but something on a molecular level prevents those differentiating nephron progenitor cells they stay in that stem-like progenitor state, and they persist much longer than they normally would in normal development, and that's what constitutes a nephrogenic rest.
I just want to add, it's a really good question. Actually, we were telling Robyn earlier that about 2 weeks ago, Keri, Andrew, myself, and about 5 other people who do research in Wilms tumors all realized we're all trying to study nephrogenic rest. We're all applying the techniques we're kind of talking about here to try to understand them and how they develop into Wilms tumors. And we're all facing the same barriers of, well, the barrier of funding as always, but also the barrier that they're hard, they're rare, they're small, and it's hard to get, in a single institution to get a good sample size to actually study them. And so we are actually now actively working as a small working group, the 3 of us and a few other people, to try to work to overcome those barriers so that we can each apply our own kind of techniques and research techniques to study these, to answer these exact questions of where do they come from. We think we know where they come from, but to validate that. And then how do they turn into tumors? And there's a really old study that suggested that there's a proportion of children who unfortunately died of other causes, nothing to do with tumors, who were found to have nephrogenic rests, and a way higher proportion than whoever would develop tumors. So we know that a bunch of them just kind of go away. And what's the difference between those? And that's really what we want to study.
And I'll just add that we're just starting to explore this with the mouse models so that we can introduce the mutations to the developing kidney, and then we can see mice that form tumors, and then we can also see lesions that either look like they may have been a nephrogenic rest that became atrophic and scarred versus still maintained some of those features of the developing kidney that would suggest this could be a precursor lesion. So again, studying these things in the mouse, there are some challenges, but we have some tools that we can use to overcome that. And hopefully this can be a model to help provide some insight into that as well.
Well, I'd love to follow up about a point that Dr. Murphy made about the fact that that Wilms tumor, for some reason, is tougher to develop into these PDX models. So first of all, I want to verify that I have that right. I've heard this before. And second of all, could you go back for just a second and talk about the role that tumor donation or tissue donation plays in being able to bring the field forward, essentially, and what does that look like? How do families get involved in that? Is that something that they're asked to do? Is that something that they seek out to do, et cetera? Could maybe Dr. Murphy, would you be willing to maybe talk a little bit about that?
Yeah, so to the first part of your question, so what's typically done to establish a patient-derived xenograft is, the tumors are minced up and they're transitioned into single cell suspension so that it's no longer a, block of tissue. It's like a slurry of single cells. And those are injected into the flank of mice. And when we used that approach, we only have an engraftment rate of 10%, which is extremely low. Whereas if we implant a chunk of tumor about the size of a pencil eraser head, the engraftment is about 70%. So yeah, the overall engraftment rates, especially if you use the conventional technique of injecting single cells, are much lower than other pediatric cancers. I don't know exactly why that is, although it implies that the cells either like to be in contact with one another or they really are dependent on being in contact with components of the extracellular matrix, which is basically like all of the stuff holding tissues together outside of the cells. And I think it may pertain to these cells needing some of the supportive environment from their developmental origin. Tissue donation is absolutely critical. Again, because we don't have a large host of immortalized cell lines that are representative of tumors, and we're often going back to primary tumor specimens as the tried and true source of some of these biologic findings in Wilms tumor. In other settings, we may have the luxury of the tumors being more common or more studied, more models. even a lot of publicly available data, but we don't have any of those luxuries for the most part in the study of Wilms tumor. And so we're still at the stage of needing primary tumor tissue in order to figure out some of these concepts. So it's absolutely critical.
Yeah, it's really helpful to know. And kind of to that point, I'd like to step back and talk about the liquid biopsies and the circulating tumor DNA, because that also requires, family participation, right? Because we need some type of a donation in order to be able to study that. So in addition to just kind of jumping in and talking about liquid biopsy and ctDNA, there is a question, and this comes up a lot. How far are we away, if at all, from being able to use liquid biopsy or circulating tumor DNA for, and I know there's a variety of purposes that we could use it for, right? We could use it to better understand the diagnostic phase. We could better, use it to better understand the evolution of disease and things like that. So can we step back, Dr. Brzezinski, and maybe others here, and talk about what are your greatest hopes for liquid biopsy, and how far are we from being able to use it for the things that you're hoping to use it for?
Yeah, so and I apologize. I meant to type in an answer to a question, accidentally clicked answer live about cell-free DNA. So I think there was a question there that asked whether it's clinically available now, and the answer is no, not for Wilms tumor yet. There's no lab that I would rely on right now to give you a clinical answer for cell-free DNA. You could potentially, there's some research studies that are open that will feedback answers to you, but they'll be on a research basis. I think that it depends on the question you're asking. If you are asking, can I diagnose a Wilms tumor in can I diagnose a Wilms tumor? And the answer is probably yes in certain cases. We have some answers from cell-free DNA where we can say that is, if you get the answer, it is a good positive, but if you don't get the answer, you don't really know what's going on, if that makes sense. So it works when it works, and when it doesn't work, it's not helpful. So we can't really tell you it's a negative. That's part of what I'm trying to work on. I think that the work that I'm doing, and there's actually another group in Boston doing very similar work, will be able to definitively tell you, no, it is not a Wilms tumor, along with the few where it says, yes, it is a Wilms tumor. That is something that I think I would guess could be in clinic within the next 5 years. To just say this is a Wilms tumor or not a Wilms tumor, I think that can be very soon. Doing things like prognostication, I think some of the easy prognostic questions will also be in clinic probably in the next 5 years. Where I'd really like to see it go is patients who have a predisposition to Wilms tumor, and can we detect it early? And that's actually a study that we're working on and talking about collecting samples. The only way we can do that, because it's a relatively rare group of kids, is we have a number of institutions. We have 10 right now who are working together to do it. And that's how you do this sort of things. You have to do it through big institutions and collect together. I don't think that'll be within the next 5 years. I think that's going to take longer. And I think that's going to need a concerted effort, which we're working on. But I think the bottom line is I think we're going to get there for diagnosis relatively soon. I think for other things, we are going to get there, but not probably in the next 5 years.
Thanks so much. I just wanted to take a quick moment. There's another question in the chat about blastomal cell dominance and whether or not you all believe that it's still highly treatable and curable, and there's no predispositions in this case. Does anybody want to weigh in on that as our final question today?
Well, I just wanted to mention that blastomal predominant Wilms tumor only correlates with prognosis if it's found to be blastomal predominant after neoadjuvant chemotherapy is administered. So if it's blastomal predominant in an upfront surgical resection, as would be like the typical practice for most unilateral Wilms tumors in the United States, it actually doesn't correlate with prognosis. If it's blastomal predominant after neoadjuvant chemotherapy, it warrants intensification of therapy. However, highly treatable and curable, I would say yes, there would be high hopes for treatment and cure in that setting, even with blastemal predominance after neoadjuvant therapy. I don't know, Jack, if you want to get more specific on the
No,
highly treatable and curable part.
No, I think I agree with you. I think that's correct. If you have blastemal predominance with an upfront nephrectomy, so you did not get chemotherapy first, it is going to be the same as any other Wilms tumor and doesn't really tell us anything. Because the idea is that the blastema is actually should be very sensitive to chemotherapy, right? So if you have mostly blastema, it should be a sensitive tumor. But if you give chemotherapy and the blastema is still all there, that's on you. Oh God, that part should have been sensitive and it's not. And that's actually a big part of what, like, when Andrew's talking about looking at the different components, trying to figure out how each one is individually targeted, trying to get to that. And the group in Europe is a little bit better at this also because they give chemotherapy before surgery to most of their patients. So they just tend to have more data on what that looks like. But even then, there's there's good therapy. We know we need to intensify for those patients.
Well, thank you so much to all of you. I know that there are a couple of extra questions in the chat. We are going to try to answer those after this session is over. I know there's about 100 things we could talk about research. I know that everything that you guys do just really gives me a lot of hope for the future. And we will continue to do everything we can to support the work. I'm going to go ahead and just say thank you so much for your time and your expertise today. And looking forward to more conversations like this in the future.